Morning, all of you. Today's topic of discussion is proton beam therapy for oropharyngeal cancer. TorpedO phase 3 randomized control trial. IMRT introduction. IMRT with the concurrent chemotherapy, standard care for the locally advanced oropharyngeal squamous cell carcinoma. Most of the patient cured, but severe late effect in quality of life. So, poor swelling outcome. MD-ADI scores can affect one-third of the patient 2 years after the treatment, with the decline of University of Washington quality of life physical functioning score at 12 measure these effects. IMPT, intensity modulated proton therapy for oropharyngeal squamous cell carcinoma, can reduce radiation dose to the OAR, including contralateral parotid, oral cavity, and solen structure, which is potentially associated with the fewer adverse physical effect compared with the IMRT. So we designed a prospective randomized trial to assess the clinical benefit of IMPT over IMRT for oropharyngeal squamous cell carcinoma. TorpedO was a phase 3 multi-centric open-label randomized control trial done at 20 UK National Health Services Hospital. With the inclusion criteria, candidates have a newly diagnosed oropharyngeal squamous cell carcinoma were suitable for the concurrent chemoradiotherapy, including bilateral exclusion criteria, feeding tube insertion required for the nutrition before the treatment, three disease, upfront neck dissection, use of induction chemotherapy, contraindication to use of cisplatin for cycle 1 concurrent chemotherapy, previous head and neck radiotherapy as well. The trial was investigator initiated and sponsored by Institute of Cancer Research and approved by the North West Greater Manchester West Research Ethical Committee. All participants provide written informed consent. Participants were centrally randomized 2:1 to IMPT or IMRT by the local referral center by minimization with random element. Treatment was not masked. Balancing factor was randomizing center, site of disease, D stage, bilateral neck node, P16 factor, and smoking status. Procedure and treatment. Both the group received 70 grade to the therapeutic target volume and 56 grade to area of lower risk of microscopic disease in 33 once daily fraction over 6.5 weeks. Target and OAR outlining and planning were standardized using the same planning priorities and challenging OAR dose target to ensure full optimization. For IMPT planning, 5 beam were typically used with the split target approach that aimed to avoid region of anatomical instability and dental amalgam to reduce the dose to the normal tissue and to maintain to be treating all the target volume. The IMT plan underwent robust optimization and evaluation using plus minus 3 mm setup error and plus minus 3.5 range uncertainty. Those distributions were recalculated across multiple uncertainty scenario and worst case target coverage and OAR dose were assessed to ensure clinically acceptable treatment delivery despite potential positioning and range error. Because proton beam are highly sensitive to uncertainty, planners must verify that the treatment plan remain effective even small error occur during the treatment. For IMRT planning, 3 CBCT were taken for initial plan and weekly thereafter. Those calculation and radiation therapy replanning followed standardized criteria which were the same for the both type of treatment. Radiotherapy replanning were performed when the target coverage of the tumor did not meet the D99 and D95 protocol criteria. If cumulative dose to the critical OR exceed by the more than 2% over tolerance, and if mean dose to parotid, oral cavity, and submandibular gland increase by the more than 3 grade. Concurrent chemotherapy given cisplatin 100 milligram meters per day 1 and day 22 during the course of radiotherapy. If cisplatin is not possible, then go for the carboplatin substitute if required because of the side effect. Prophylactic and reactive feeding tube placement followed the pre-specified policy of the referring center, independent of the treatment allocation. Weight and feeding tube dependence was assessed weekly during the course of the radio chemotherapy, then at the 6 week, and then 3 week, 3 months, 6 months, 12 months, 18 months, and 24 months after the completion of the treatment. Acute toxicity measured by the using of CTCAE 5. Assessment time during the course of chemoradiotherapy, 6 week post treatment, and 3 month post treatment. Late toxicity by same using of CTC5 Landsoma criteria, and at the time of 6 months, 12 months, 18 and 24 months. Functional outcome assessment by the water swallow test and PSSHM performance status scale for the head and neck cancer patient, assessing eating in public, speech instability, and normalcy of diet. Assessment at the time of baseline, 3 months, 12 months, and 24 months. Patient reported outcomes by the using of UWQL score, primary endpoint, head and neck specific quality of life, URT's quality of life questionnaire, QLQ C30, general cancer questionnaire, quality of life head and neck module, QLQ HN43 score, MADI score, solving related quality of life, work producibility and activity impairment, specific health problem questionnaire score, collected at the time of baseline and of treatment, 6 week, at the 3 months, 6 months, 12 months, 18 months after the concurrent radiotherapy, and then annually up to the 5 years. The outcome of this study is co-primary endpoint at 12 months. University of Washington quality of life physical composite score, so taking 6 factors: swallowing, chewing, speech, taste, saliva, and appearance. At the time, same time, four and more factors were studied. Gastrostomy tube dependence used in the past 3 week or CTC grade 3 weight loss more than and equal to 20% weight loss. Secondary endpoint, UWQL score endpoint at the 12 month. In a enriched cohort defined by the normal tissue complication probability anti-CP model, and the anti-CPT model cohort study assess the patient predict to benefit most from the proton therapy had better quality of life outcome. Other secondary endpoint, weight loss more than and equal to 10%, feeding tube status, acute and late toxicity, swallowing and functional outcome, and cancer outcome. Stats analysis for the gastrostomy tube dependence or grade 3 weight loss, assuming a 25% IMRT event rate, 165 total patient participant assess, 110 IMPT and 55 for IMRT, provide 80% power to detect OAR of 0.23, two-sided 2.5% of alpha for UW quality of life physical composite score assessment. 156 participant in which 104 IMPT and 52 for IMRT provide power of 86% to detect 8-point improvement, representing a moderate and clinical importance increase in the mean score at two-sided 2.5% alpha. The result of resulting sample size correspond to effective inflation of 22% for the patient reported co-primary endpoint, giving a required total of the 201 participant. जो ऊपर के दो असेसमेंट हुए उसके बाद फिर अपने को इफेक्टिव इन्फ्लेशन 22% बढ़ाया, तब जाके अपने को एक टोटल डाटा मिला सैंपल साइज का कि 201, तो अपने को सैंपल साइज यहाँ से मिला. We used modified intention to treat population because excluded patient because of the early recurrence, death, withdrawal, and missing data before the 12 month. Follow-up window 10 to 15 months. Stats multivariate linear or logistic regression used. Total patient enrolled for this study is 205, in which IMPT group में 136 patient लिए और IMRT में 67 patient total लिए. Most of the patient are male, 163, and female are 42. Mean age is 57. Primary disease site is tonsil, 57%, and base of tongue are 42%. P16 status 96% positive. Majority had HPV associated oropharyngeal cancer. Smoking history 46% are never smoked. Ex-smoker are major portion. The tumor stage T1 T2 is 52% and T3 T4 is 48%. Bilateral neck involvement absent in 79%. मतलब ये N0 N1 stage वाले हो गए. Or median BMI is less than 30 kg per meter square. No feeding tube before the therapy. These are the tests are using in this trial. Kaplan-Meier method for survival analysis, Cox regression for hazard ratio, acute adverse event assessment up to the 3 months after radiotherapy, late adverse event assessed for more than 3 to 2 years, chi-square या Fisher exact test for proportion for late and acute event, Wilcoxon rank sub test using for OER dose comparison. Von Fahrenheit correction applied P value less than 0.025 significant for co-primary endpoint. All analysis were based on the using data S data version 19, and the study was registered with the ISR CTN registry. Results between this study was conducted Feb 25 Feb 2022 to June 23, assigned to 205 patient, in which already 136 for the IMPT and 69 for the IMPT. In this diagram showing 205 patients were taken, 136 assigned for the IMPT, for which 132 received radiotherapy and 119 acute analyzed for the critical gastrostomy tube dependence or severe weight loss, and 99 for the patient reported University of Washington quality of life mean physical composite score. And for IMRT, 69 patients were assessed, in which 67 received radiotherapy, 59 for gastrostomy tube dependence and severe weight loss, and 55 for the quality of life score. In this diagram, showing most of the cases are 48% are T3 T4 and 22% with the bilateral neck node involvement, only 22%, and 80% are male and 20% are female, most of the white British. This is the table delivery and radiotherapy interruption for the IMPT and IMRT. Received allotment treatment is 130 to 97%, and in IMRT 67 cases did not receive allotment treatment is 3%, and same in the IMRT. Total plant fractions is 4356 in IMPT and 2211 in IMRT. Missed fraction is 133%, and in IMRT less than 1%. Patient with missed fraction 49%, and IMRT में 4%, and compensation by the PK treatment 50% of the missed fraction, and compensation in IMPT. Compensation by the twice daily treatment 48% of missed fraction. In IMPT, additional fractionation added to the end of the treatment is 2%, and no fraction added in the IMRT. Patient received more than 6 fraction per week, 0 in both the modality. Cross modality compensation, one patient received single IMRT fraction in IMPT. Reason for the treatment interruptions for IMPT: equipment failure, cyclotron breakdown, scheduled service maintenance, and acute adverse event are the reason for the treatment interruption in IMPT. And for the IMRT, major is acute adverse event, major reason, and bank holiday is another factor. Planning required, replanning basically more in the IMPT. In 81 cases 61%, and IMRT में 20 cases में हुआ है 30%. Received concurrent chemotherapy 100% in both the modality. Adaptive replanning was required twice, as frequently with the IMPT, 61% compared to the IMRT. This reflects greater sensitivity to of proton dose distribution to the anatomical changes such as weight loss, tumor shrinkage, and change in the neck contour during the treatment. With the concurrent to cisplatin given to the IMPT 67% cases and IMRT 73% cases. Cisplatin to switch carboplatin in 27% in IMPT and 21% in IMRT. 2 cycle of carboplatin in 2% cases in IMPT and IMRT में 1% cases में दिया है और 1 cisplatin cycle only in 4% in IMPT and same in the IMRT. Co-primary endpoint gastroctomy due dependence or grade 3 more than 3 weight loss or at the 12 month. Evaluable patients are 199 in 67% cases in IMPT, proton therapy and radiotherapy 59 cases. Event rate 21 cases, 18% in proton therapy and IMRT में 7%. 97.5% CI, 11 to 27% in proton therapy and 2 to 18% in IMRT. Absolute difference is 11%. Adjusted odds ratio 2.80 and p-value is 0.079. So composite endpoint occur more frequently with the proton therapy 18% than IMRT 7%. Although numerically unfavorable for IMPT, the difference does not reach stat significance. Adjusted OAR is 2.8 and P is 0.079. Component of composite endpoint grade 3 or more weight loss 20% in the proton therapy 20 out of 10 18% cases and 3 out of 53 in radiotherapy. Gastrostomy tube dependence at 12 months 2 out of 119 2% cases in the 1 in radiotherapy. The availability of endpoint data both feeding tube and weight loss showing in the 110 patient in proton therapy and IMRT में 53 cases में केवल feeding tube in 9 cases में और radiotherapy में 6 cases. Weight loss दोनों में 0 ही है. Total patient is 119 and 59. Feeding tube use at any time. Proton therapy में 45% 61 cases out of 135 and 40 out of 16 58%. More feeding tube used in the radiotherapy and prophylactic feeding tube जो है वो 26% in proton therapy and 38 in radiotherapy में IMRT में यूज हुआ है. Severe weight loss feeding tube यहाँ पे ज़्यादा हुआ है इसलिए weight loss यहाँ पे कम हुआ. Severe weight loss more in the 18% in proton therapy and radiotherapy में 6%. Long term feeding tube dependence equal in both. The weight loss outcomes median weight loss at the time of treatment 6% in proton therapy and 7% in the radiotherapy. Grade 3 weight loss at the time of concurrent chemoradiotherapy is 0. Grade 3 weight loss at the 6 month 20 out of 116 17% cases and 3 out of 56 5% cases. Grade 3 weight loss at 12 month 18% and 6%. At 24 month 13% and 0 and underweight at 12 month 2% and in radiotherapy 4%. Although IMPT patient experience more long-term weight loss more than 20 and equal to 20%, 18 versus 6 at the 12 month. Very few become underweight and feeding tube dependence remain low, suggested that clinical significance of weight loss difference is uncertain. These are the factor of questionnaire I have written here. And primary quality of life endpoint. University of Washington quality of life physical comfort at 12 months. Evaluable patient 154 in 99 in proton therapy and 55 in IMRT. Adjusted mean composite score at 12 months is 73.3, 97.5%, and 77, which are almost equal, 77.1%. And difference between IMPT minus IMRT plus 1.3 point. 97.5 confidence conformity index for the difference is minus 3.7 into 6.2. P value is 0.5. This is a bar diagram showing University of Washington quality of life appearance over that various, in which blue has no change in the appearance, and gray part change in the appearance with minor, and green appear, but patient remain active in the green part. So majority cases are in this scenario with the time about 24 months. UWQL physical composite score during the follow-up. During chemoradiotherapy, IMPT mean score was declined in both IMRT, same. During radiotherapy, दोनों में decline है. After 3 months, 78.8 cases and 66.8, slightly better with the IMPT, not significant. At the 12 months, 78.3 and IMRT में mean score 77.1 plus 1.3, similar quality of life between the groups. And 24 months 81.6 and IMRT में 79.9 plus 1.7, continue recovery, similar outcomes. QL physical score worsening during the chemoradiotherapy, then improve steadily over the time in the both group. By the 12 and 24 month, IMPT and IMRT produce very similar physical quality of life outcome. Most patients recovered swallowing, chewing function, although taste impairment and dry mouth remain common long-term symptoms. Symptom recovery timeline. At the end of the chemoradiotherapy, worse quality of life score, swallowing, chewing, taste, and saliva markedly affected at the time of 6 weeks. Difference between IMRT and IMPT largely resolved. And 3 to 6 months, 10% of the patient could swallow liquid only, had complete taste loss, no saliva. At the time of 12 months, most patients recovered normal or near normal swallowing and chewing function. 20% could taste only some food, and 40% still had reduced saliva, dry mouth. At the time of 24 months, further improvement, and IMPT, IMRT remains similar. In this overall table, overall enriched cohort में IMPT score at 78.5 and IMRT score 77.5, and difference is plus 1 not, no significant difference. And NTCP enriched cohort में 78.2 IMPT score and IMRT score is 75.8. Difference between IMPT and IMRT is plus 2 point. No, that is also not significant. Despite of superior or we are sparing with IMPT, neither overall population nor NTCP enriched subgroup show statistically significant improvement at 12 months in the quality of life compared with the IMRT. Dosimetric result, toxicity outcome, and secondary endpoint of the TorpedO trial. OAR radiation dose lower in the IMPT proton therapy, and highest priority structure lower with the IMPT, and dose consistency similar first and second half of the trial. The proton therapy successful reduce radiation dose to the normal tissue compared with the IMPT. The grade 3 toxicity more 66 cases out of 132, 50% in proton therapy, and IMRT में ज़्यादा है 72%. IMPT significant severe acute toxicity, and oral toxicity grade 3 mucositis. Grade 3 mucositis 49 cases, only 37% cases में, और 36 cases 45% in radiotherapy. Grade 3 dysphagia 12% in proton therapy, and IMRT में 24%. Grade 3 dysgeusia test changes in 42% cases proton therapy and 66% in radiotherapy. Patient receiving proton therapy had less severe mucositis, less swallowing difficulty, and less taste disturbance during the therapy. Death were 10 in 7% of proton group versus 4% in radiotherapy, and 24 overall survival rate were 95%, 99% of CI, 86 to 99 in IMPT group versus 95%, 81 to 99 in radiotherapy. This is the first randomized controlled trial with the primary objective to investigate late effect and quality of life difference between proton therapy and IMRT for head and neck cancer. For oropharyngeal squamous cell carcinoma, proton therapy neither reduced late gastrostomy tube dependence or severe weight loss, nor improved long-term patient reported physical HR quality of life or swallowing function. The validated University of Washington Quality of Life Physical Composite Score assess patient-related symptom and reduction in the side effect from the anticipated OR sparing with IMPT versus IMRT, and HRQOL decline during the therapy improved from the month 3 to 12, then stabilized, making the 12-month endpoint a reliable measure for lasting radiation effect. Gastrostomy tube dependence at 12 months was low in both groups, severe grade more than weight loss at 12 months, more frequent with the IMPT than IMRT, and UWQL score for swallowing, chewing, taste, saliva were similar between the group at from the 6th week after the chemoradiotherapy onward. The subset of patient in both IMPT and IMRT group reported persistent moderate to severe symptoms throughout the follow-up. The lower rate of feeding tube placement with IMPT compared with IMRT at the end of the treatment, combined with a possible reluctance by patient and clinician to insert tube after the completion treatment, probably contribute to a greater subsequent weight loss observed in the proton therapy. Prophylactic tube placement was more common with radiotherapy than proton therapy. Late PRO and functional outcome were similar in the both groups. For UWQL score at 12 months, most patients reported mild swallowing difficulty, avoiding certain solid food, had normal taste for the most food, and reduced but adequate saliva production with no difference between proton therapy and radiotherapy. The proportion of the patient with a late radiation related grade 3 event show less reduction from the acute to late phases in the proton therapy group than radiotherapy. Numerically higher rate of late grade 3 event with the proton therapy group than in the radiotherapy group, therefore reflect more new event for proton therapy than in radiotherapy. Hearing impairment was common in both groups with the cisplatin as a contributing factor. Other radiotherapy related grade 3 event were observed in 6% of the patient in proton group, 3% in radiotherapy group. Previous data, MTACC clinical trial reported that grade 3 events were uncommon in both the group. Long-term gastrostomy tube dependence and late PRO for the IMRT better than the previous report, probably due to the fully optimized functional sparing radiotherapy, which is better protected swallowing structure than salivary gland. During the final week of the chemoradiotherapy, UWQL physical composite score is higher in the IMPT group than in IMRT group, indicate better physical functioning and quality of life during the treatment. This is a table at the baseline. UW result score, similar score, no significance, no clear advantage of proton therapy. During the radiotherapy, during chemoradiotherapy, higher score with the proton therapy, significance yes, better physical quality of life during the treatment, less treatment related burden, better swallowing, chewing and saliva related symptom. At the end of the treatment or to the 3 months, numerically benefit favoring for the proton therapy, but not clearly significant. Lower acute grade 3 toxicity, less acute mucositis, better patient reported experience. At the time of 6 months, similar outcome, similar score. No significant नहीं है. 12 month IMPT 78.5 and IMRT 77.5 significance नहीं है. No long term quality of life benefit. At the time of 12 month IMPT 78.2 and IMRT 75.8. No significant difference, and even high benefit patients show no significant quality of life at the time. At the time of 12 month, 18 month and 24 month, no difference between both the groups. IMPT achieved significant OAR dose reduction, confirming its dosimetric advantage over the radiotherapy, but did not necessarily mean better patient reported outcomes. Proton and photon plan can have similar mean dose, but different, very different intra-organ dose distribution. Proton beam are more sensitive than photon beam to anatomical variations such as tumor shrinkage and weight loss. We observe higher replant rate in the proton therapy group and then IMRT group. The limitations in this ethnicity, 98% are white, black, Asians, and other minority group are there in lesser amount. Different proton center may use different planning technique, different robust parameter, different quality assurance framework. LET guided optimization was not used. Fixed RVE of 1.1 was used. Still under active research. Modified intention to treat analysis instead of full intention to treat population included patient who were cancer free at 12 months during the chemoradiotherapy, and potential for the bias because recurrence and death after randomization were excluded. Bias was minimized in the trial. Similar baseline and treatment compliance, no crossover between the groups, similar OAR dose in the first and second half of the trial. Prospective contouring and planning protocol, very few machine interruptions, total dose and treatment duration maintained in the both group. Local regional control and overall survival were excellent in both the group, including adverse clinical feature. So conclusion of this trial, no significant difference between the proton therapy and radiotherapy in late toxicity, quality of life at 12 months, gastrostomy, tube dependence, swallowing function, local content, and overall survival. The main benefit of proton therapy was reducing acute toxicity only, particularly during the treatment, rather than improving long-term outcome. Modern contouring and advanced function sparing IMRT achieve better outcome than historical IMRT series. So both proton therapy and IMRT are highly effective treatment for oropharyngeal carcinoma. IMRT remain standard of care in healthcare system, but where proton therapy is not routinely available. Modern functional sparing IMRT remain excellent standard treatment, while the proton therapy offer selected advantage mainly on acute toxicity reductions.